Well, hello and welcome everybody to this presentation on physician-assisted suicide, which is the abandonment of Hippocratic medicine. My name is Mark Rollo, and while we're waiting for additional people to join, I wanted to thank a couple of people. First of all, I want to thank my good friend William Lawton, Dr. William Lawton, the late Dr. William Lawton, who was a nephrologist, and he practiced in Iowa, and he retired after practicing in Iowa and moved to Massachusetts to be closer to his family. And instead of getting into a rocking chair, he did a number of things, one of which was to go to Africa to teach people how to do dialysis. And he also took on the challenge of fighting physician-assisted suicide in Massachusetts. And he went around the state, this is 5 or 6 years ago, and he gave several presentations, and I joined him at one point, and I am using some of his slides. So I wanted to give credit to him for some of his slides that I'm using. And he was a real inspiration because he walked the walk and talked the talk. At the end of his life, he died from pancreatic cancer. He testified before the Public Health Committee in the Massachusetts legislature, and while dying from pancreatic cancer, fought passionately and spoke passionately against physician-assisted suicide. And after that, he died about within a few months of that last time that he testified. So I wanted to give recognition to him. I also want to thank James Capuzzi, who's helping me now. Since I'm not very tech savvy, he's going to be helping me. He already helps set everything up. And in case something goes haywire, he'll be able to bail me out, I hope. So having said all that, I also want to mention that this is being recorded. So at some later date, you should be able to gain access to it, or other people who aren't joining us now can gain access to it. So with that, again, my name is Mark Rollo. I'm a family physician of over 35 years, having recently retired. And during my 35 years of practice, I have seen the gradual erosion of Hippocratic medicine to the point where it is actively being toppled because of physician-assisted suicide. Now, this is not a new issue. This is a moral debate that has been going on for 2,500 years, and it started with Hippocrates. Hippocrates practice in a death culture much like our own is becoming. The Greek and Roman world at the time, it was very common for physicians to kill their patients if they couldn't cure them. They didn't have much in the way of therapeutic armamentarium, so often they would kill their patients if they couldn't cure them. And Hippocrates realized that patients wouldn't trust them and didn't trust their doctors because they had the power to kill them. And so the Hippocratic Oath, very specifically, unlike the watered down versions of today, which is not much more than a pile of platitudes, the original Hippocratic Oath said, "I will neither give a deadly drug to anybody if asked for it, nor will I make a suggestion to this effect. Similarly, I will not give to a woman an abortive remedy." So these twin temptations of killing were present back in the Greek and Roman times, just as they are now. And I think personally that it was the toppling of the abortion prohibition that kind of led naturally to the gradual onset of laws around the world to allow physician-assisted suicide. Hippocrates understood what we as a culture increasingly do not understand. that a physician cannot be both healer and killer and maintain the trust of his patient. It seems pretty straightforward, but a lot of people don't get it. I was talking to a fellow physician from Oregon by the name of William Toffler, who was one of the original fighters against physician-assisted suicide. And in 1997, when it became legal in Oregon for a doctor prescribed suicide, physician-assisted suicide, he noticed right away that patients acted differently. And some outright asked him, "Are you one of those death doctors?" So the situation now, and a lot of people, I must say, are kind of pessimistic about physician-assisted suicide eventually becoming legal across the country. But I don't share that pessimism. And the reason is because the first state to fall was Oregon in 1997. That was 25 years ago. Now, if you remember the whole abortion situation, and by the way, I'm mentioning abortion now, but an important point is to, when we are arguing for physician-assisted suicide, we should stick to that issue and stay only with physician-assisted suicide and not be caught trying to defend other things. But just to make the point, as many of you may recall, it was in the 1960s, the late 1960s, that abortion became legal in a few states. And within less than a decade, we had Roe v. Wade, and it was legal across the country. Well, that's not the case with assisted suicide. As you can see, there are 9 states, and this is a slide from last year. So there was one additional state. So now there are actually 10 states with a legalization of physician-assisted suicide in New Mexico last year. But the red states, and including the District of Columbia, have laws on the books for assisted suicide. That's only, roughly 20% of the country. So 80% of the country does not have physician-assisted suicide. And those green states, those 11 green states that you see, they are states that prohibited physician-assisted suicide since the initial state fell, which was the state of Oregon in 1997. And there are 28 states, now 27 with New Mexico being flipped, but there are 27 states, those blue states, which already had laws on the books or had common law which prohibited physician-assisted suicide. The state of Montana is a special case. They legalized physician-assisted suicide by way of a court case. And so there are 2 states that don't have any laws one way or the other, Nevada and Utah, or I'm sorry, Wyoming. So again, the majority of states do not have physician-assisted suicide. So we must be optimistic, and we must continue to fight this. So what is physician-assisted suicide? I like the description of doctor-prescribed suicide better because it's more specific about what a doctor does. A doctor writes a prescription, gives it to the patient fills the prescription, takes it home, and takes it without any medical supervision. Historically, most of these suicides occur without any kind of medical assistance. It's about only 15% that has medical supervision. So this could be a drug, a poison that is taken by the patient by himself. Maybe the family's around. Maybe somebody in the family or somebody else is being coercive. A lot of times they're not taken at all. And so these dangerous drugs are sitting on a shelf somewhere, and they could be taken by somebody else, or they could be surreptitiously given to a patient without their knowledge. So it's a very dangerous situation. Now, so physician-assisted suicide occurs when a physician helps a person take his or her own life by writing a prescription for lethal medication, I don't even like to say a medication. It's a poison, which allows the person to commit suicide. Whereas euthanasia is more active still. And this occurs when another person does an action with the intention of ending the life of a suffering patient. Now, an interesting aside, which I just learned about a few weeks ago when I was talking to Dr. Lawton in Oregon, I asked him, why did the people who were promoting this, why did they pick Oregon? And he told me that they initially tried to legalize active euthanasia in California and Washington. And this would involve injecting people. And this was too horrific at the time. This was too abrupt. And so it failed in California and it failed in Washington. So they came back and they took a step back and they said, well, let's try to ease into this and let's make it an assisted suicide. So it's actually the patient who's taking the drugs. But their intent is to go on the slippery slope and make it more active euthanasia. And in fact, this is what they do in the Netherlands. And in fact, in the Netherlands, they have involuntary euthanasia. In Canada, they have active euthanasia. They have doctors give injections to actively kill patients rather than write a prescription for the patient to take. But that is the end game for the people who promote this. I forgot to say at the outset, and I'll say it now, that there is, for people who are viewing, if you have any questions as we go along, write them in the chat box, and James Capuzzi will be reading those to me at the end of the presentation. My presentation will last about 40 minutes or so, and they'll be in 20 minutes or for however long people want to remain online. And those questions or comments can be addressed to me. So I like the definition of this man, and some of you may recognize him. This is C. Everett Koop. He was a pediatric neurosurgeon, and he practiced, or he was the Surgeon General under Ronald Reagan. And his definition was, I have always defined euthanasia as death by someone's choice, someone who considers the life in question no longer worth living. Now, considering somebody's life no longer worth living is very dangerous. And physician-assisted suicide is dangerous for many reasons. And I will go through these. And these are all going to be secular arguments. There are plenty of religious arguments to be made, but we're in a secular culture for the most part. And when we're speaking to legislators especially, we want to be using secular arguments. So the first danger is that doctors make mistakes. Doctors make mistakes both in terms of diagnosis and prognosis. Now, you may recognize this person. This is Stephen Hawking, the famous astrophysicist who discovered many things, among them black holes. And he was diagnosed with ALS, Lou Gehrig's disease, when he was 21 years old. And he was told at the time that he only had a few years to live. Well, he lived much longer. He lived 50 years, more than 50 years after he was diagnosed at age 21. So this was a huge mistake in prognosis. And where would we be without his brilliance in astrophysics? Another person who had ALS was a person who testified at one of the hearings several years ago. I was testifying in front of the Joint Committee on Public Health at the Massachusetts legislature, and other people were testifying as well. And one of them was another person who had been diagnosed with ALS, Lou Gehrig's disease. And it turns out they made the wrong diagnosis. And again, where would he be if there was the option of assisted suicide at that time? So doctors make mistakes, both in terms of diagnosis and prognosis. Another danger, physician-assisted suicide is a recipe for elder abuse. Now, during the time that I practiced medicine, I had a lot of elderly patients. My youngest patients were in the womb, and my oldest patients were over 100. And as time went on, my patients were living longer, and I had many elderly patients. And they would come into my office, and they would say things like you see on the screen. I feel like giving up. I'm tired of living. Doc, don't get old. I don't want to be a burden. Now, depending on the mindset of the physician and the legal environment, statements like this can be taken down two very different pathways. Either a pathway of encouragement and hope, or a pathway of despair and death. Now, this is not one of my patients. This is Kate Cheney. She was one of the original victims in Oregon. She was a lady who had cancer, and she had mild dementia. And her daughter, Erica, took her doctor shopping. She took her mother, Kate, to see the primary care doctor asking for assisted suicide. The primary care doctor knew Kate and said, well, no, sure, your mother doesn't really understand what's going on. I don't think she's a candidate for assisted suicide. So he refused. Undeterred, the daughter, Erica, took her mother to see a psychiatrist. And the psychiatrist also agreed that she didn't really understand the ramifications of assisted suicide. And he made notes indicating that he felt that the daughter was being coercive. Still undeterred, the daughter took Kate to a so-called ethicist at the HMO where her mother went. An HMO, as you probably know, is like a quasi-insurance company. You get your medical care, and it insures you as well. Well, the HMO had a financial interest in the early demise of Kate, and within a few weeks, they decided that she was a perfect candidate, and within a few weeks, she was dead from an overdose. So the chances for elder abuse are immense. It's estimated that about 10% of elders are subject to some kind of abuse. And the majority of the abuse, unfortunately, usually comes from family members. Another danger is that physician-assisted suicide puts a price tag on life. Now, the first person who can financially gain could be, in this case, the daughter. Now, we don't know if she did or not. Maybe she had pure motives, but the fact of the matter is that these physician-assisted suicide laws call for witnesses, and one of the witnesses can be an heir. Now, some people are trying to make it more palatable and removing that, but still, there can always be a third person who could be making the request, and they could be sharing in the estate of the person who dies. So there's all kinds of room for mischief. Not only that, but insurance companies have a vested interest in saving money, and they may steer people, and they have, and I'll give you some examples of that. They have steered people towards suicide. Government as well. So government payers like Medicare, Medicaid, they will have an incentive to steer people toward the cheap solution of suicide. Now, some of you may have already experienced something similar or a kind of rationing. How many of you have gone to the doctor and the doctor wanted to get an expensive test like an MRI, only to find out that the insurance company said, well, no, we can't do that. We have to get prior authorization. And or another example, a physician may want to prescribe an expensive medication, but the insurance company says, no, this is kind of an expensive drug. We're going to have to go through the prior authorization process, and maybe something cheaper will do. Well, sometimes that's legitimate. Sometimes, a Chevrolet will do, and you don't need a Rolls Royce. But sometimes the prior authorization makes people wait, and sometimes the waiting can end in death, or sometimes it can be outright refused, and which will lead to a more immediate demise. So another danger: laws that advantage the white, wealthy, and well-insured should not be made at the expense of the poor, people of color, the dispossessed, and the disabled. Now, this is an important argument to be made, especially in Massachusetts, where everybody's more sensitive to, issues of racism and discrimination, issues of social justice. It is true that it is the white and the wealthy who want this, because they can afford treatment if they want treatment. But if they want the option of suicide, they want physicians to do the dirty work. But the poor, people of color, the disabled, they have fewer resources, and they're the ones that are going to be steered towards suicide. Now, here is a good example of this. If you remember, in 2012, there was question 2, which was a ballot initiative, which would allow physician-assisted suicide. Well, thank God we defeated that in 2012, narrowly defeated it. 51% voted no, and 49% voted yes for physician-assisted suicide. And you can see the breakdown on the map. The pink or beige colored cities are the cities that said no. And you can look at central Massachusetts. You can look at southeastern Massachusetts, towns like Fall River and New Bedford, or in the northern sector with towns like Lowell and Lawrence. Poor, more blue-collar areas, they rejected it. They rejected physician-assisted suicide. Whereas the more affluent areas, like you can see in the green, the Boston suburbs, you can see the North Shore, Cape Cod and the islands, these were the more wealthy areas, and these areas tended to be in favor of physician-assisted suicide. And just to bring that home, here's another map of Massachusetts that's shaded according to per capita income. And it looks similar to the map of physician-assisted suicide voting. Again, the wealthier areas are the suburbs of Boston, the North Shore, the Cape and the islands. So again, this is another danger, that it's going to discriminate, that people of color, the poor, the disabled, they're the ones that are going to be steered towards suicide. Now let's get into some, this is not just theoretical, this is real. And here are some specifics. And these are good arguments to be made when you're speaking to legislators or anybody. This woman, Barbara Wagner, she lived in Oregon. She was a 64-year-old whose lung cancer had been in remission, and she learned that the disease had returned and would likely kill her. Her last hope was a very expensive drug that her doctor had prescribed for her. Now, the Oregon Health Insurance Plan, basically Medicaid of Oregon, refused to pay. But they agreed to cover the drugs for physician-assisted suicide, about $50. Now, this sounds unbelievable, but it is true. You can look it up yourself online. If you Google Barbara Wagner of Oregon, you'll get the story. And she actually received a letter. Imagine that. She got a letter from Medicaid of Oregon saying her expensive chemotherapy would not be covered, but her assisted suicide pills would be covered. So insurance companies and government see dying as a cost-saving measure, steering those with limited finances towards assisted death. Another example, this is Randy Stroop, also of Oregon. He was a 53-year-old person with prostate cancer. He too got a letter, and the letter said that his cancer was too advanced to warrant expensive treatment, but the state was willing to pay for his assisted suicide. Another case, this is a woman who lived in California. California only legalized physician-assisted suicide in 2016. Before it was legalized, she was receiving from her private insurance, she was receiving coverage for an expensive drug to treat her scleroderma. Scleroderma is an autoimmune disease which scars and destroys different organ systems. In her case, it was her lungs, and you can see in the picture that she's wearing some oxygen tubing. Well, she was a 33-year-old wife and mother at the time. She had four children. And at the age of 29, or she was, yes, so at the age of 29 in 2000, would have been 2014 or so, or 2013. But at any rate, at the age of 29, she was told she had 3 years to live. And a physician prescribed a different chemotherapy drug. And in 2016, her medical insurance refused to pay. So once you legalize physician-assisted suicide, it becomes a medical procedure, and it becomes a cheap medical procedure. And insurance companies will steer people toward suicide. She was told by her private insurance that the drugs to put her to death were covered, not the expensive treatment, but her suicide pills would be covered for a co-payment of $1.20. What a deal. She, by the way, Stephanie Packer, is still alive, and she came to Massachusetts and she testified in front of the Massachusetts legislature that she was refused initially. Eventually, she did get it covered, but she initially had to fight for this, and she was told that she could opt for assisted suicide. So this is a slippery slope, and that is basically another danger of assisted suicide, is that it does present a slippery slope where more and more people qualify for assisted suicide. This was outlined by Wesley J. Smith, who was an American attorney and a staunch opponent to physician-assisted suicide in the late 1990s. So this is like 25 years ago. He wrote this book, Forced Exit: The Slippery Slope from Assisted Suicide to Legalized Murder. And one excerpt from this book was as follows. In only 23 years, Dutch doctors have gone from being permitted to kill the terminally ill who ask for it, to killing the chronically ill who ask for it, to killing newborn babies in their cribs because they have birth defects, even though by definition they cannot ask for it. Dutch doctors also engage in involuntary euthanasia, like I mentioned before, without any significant legal consequences, even though such activity is officially prohibited. So writes Wesley J. Smith in Forced Exit, the slippery slope from assisted suicide to legalized murder. So the slippery slope is not something mythical. It's not theoretical. It is very real. It starts with the extremely ill with only 6 months to live, and then it eventually includes the severely disabled, then the moderately ill, moderately disabled, slightly ill, old, and depressed. For instance, there are some localities, Switzerland, for instance, they have basically suicide on demand. You can go to a clinic in Switzerland and other places as well. But I was just reading of a man who was about 100 years old, and he said he was tired of living. So he went into this assisted suicide clinic and was killed. In Canada, our cultural cousins to the north, they legalized assisted suicide if you had 6 months to live in 2016, just 5-6 years ago. They have already extended it to include other people, including just recently, they've expanded it to include depression. So if you're a depressed person in Canada, you can request assisted suicide. That recently passed. It hasn't yet gone into effect as far as killing psychiatric patients. And of all people, the people who depend on us the most, people who are depressed, they're agreeing to include them in assisted suicide. And I have a friend by the name of Dr. Mark Conrad, who is a psychiatrist, and he speaks of this himself. He's a professor at Johns Hopkins, and he says patients come to him and say, why can all who are very depressed, and they say to him, why can all these other people commit suicide, but not me? That's not fair. I want pills to kill myself. You can imagine this is a very, frustrating for a psychiatrist to have to deal with something like that. So the slippery slope is real. Another danger, the right to die will become a duty to die. An example of that is Brittany Maynard. Many of you may have heard of Brittany Maynard. She was on the cover of People magazine back in 2014. She was an unfortunate 29-year-old California woman who had brain cancer, a grade 4 glioblastoma. And in 2014, assisted suicide was not legal in this. Somehow my slide skipped forward, but at any rate, Brittany Maynard was in California, and assisted suicide had not passed. And so she traveled to Oregon and requested physician-assisted suicide there. And as a result, she died on November 1st, 2014. And there were some indications that she was having second thoughts, and you can almost, there's no proof of this, but with her communications, you had the sense that she didn't really want to go through with this, but she eventually did. And one wonders if she was feeling the pressure of organizations like Compassion and Choices. Again, I don't know if that was true or not, but she kind of made a commitment, and despite making some noises that maybe she didn't want to go through with this, she eventually did. And so a lot of people say, well, so what? She's an adult. She made a choice. That was her choice. But we are social beings. We don't live in a vacuum. Decisions that we make inevitably affects other people. This person, Maggie Carner, you probably never heard of her, but she was a woman who lived in Connecticut around the time of Brittany Maynard. She had a brain tumor too, like the brain tumor of Brittany. And she said Brittany's suicide puts other patients like me at risk of abuse or subtle pressure to comply with state-sanctioned suicide. Another danger is that assisted suicide removes hope for a medical breakthrough. Now imagine if in the time of Hippocrates, if they didn't forswear killing and they continued to kill patients that they couldn't treat. We would not have had the same medical progress that we have now. If doctors were just killing these patients, there would not be the pressure that comes about when you forswear that. You have that added pressure on the medical community to come up with cures. And if we legalize physician-assisted suicide, we are going to remove some of that pressure for medical breakthroughs. An example of that is another woman with brain cancer, with a brain tumor. These are two women who are on the cover of Time magazine back in 2015, a year after Brittany Maynard committed suicide, or less than a year later. And focusing on the woman on the left, she had a brain tumor. Her name was Marianne Anselmo. She was 59 years old, and she went to Sloan Kettering and took an experimental drug, and her brain tumor went away. This was and by August 11th of 2015, her cancer was gone. Now, I tried to look her up recently, and I couldn't find any evidence that she eventually died. Maybe she has by now, but I couldn't find any evidence of that. But she lived much longer than what was originally expected, and she contributed in finding this breakthrough medication to treat glioblastoma. Another person who had a brain tumor was J.J. Hansen, and as you can read at the bottom of the screen, J.J. Hansen is he eventually did pass away, but he was the president of the Patient Rights Action Fund. Now remember that name because they have a tremendous amount of good information on their website. So if you just Google Patient Rights Action Fund, you will learn about J.J. Hansen and get all kinds of good information about opposing assisted suicide. It is the nation's leading organization protecting rights of patients and people with disabilities. Well, going back to the top of the screen, he was given 4 months to live. And he said assisted suicide was not the answer. On May 23rd, 2016, the report was, as you can read, that in 2014, former Marine J.J. Hansen had the same diagnosis as Brittany Maynard, a stage 4 glioblastoma multiforme. He was treated with an experimental drug, again at Sloan Kettering, and he went into remission 2 years from the diagnosis. Hansen does not see assisted suicide as a choice that affects only the individual making it. Its influence on others should keep it illegal. Having the option to die will dishearten severely ill patients, especially those who feel that they are a burden to their families when they most need to rally their courage. So he was given 4 months to live. He actually lived 4 years, and he too testified in front of the Joint Committee on Public Health a few years ago before he died. Imagine how precious those 4 years were to his wife and his son. Another danger is that physician-assisted suicide corrupts the medical profession. Albert Einstein famously said, "Never do anything against conscience, even if the state demands it." Well, this law that is before the Massachusetts legislature does demand it, because if you read the legislation, it says that if you as a physician will not participate in physician-assisted suicide, you have the duty to transfer the patient to someone who will, as if that does not make the physician complicit. If somebody asked me to refer them to somebody with assisted suicide, I would say no, because that makes me complicit, and that would make me subject to being sued. Now, you can imagine that physicians or physicians to be, people who may want to become physicians, will see this specter of having to deal with this kind of a situation, and they may not go into medicine. So we're going to lose a lot of good people who will choose not to go into medicine. Furthermore, it corrupts the medical profession because it's legalized fraud. These bills, these assisted suicide bills, mandate that the doctor not put on the death certificate assisted suicide. You have to write the underlying diagnosis, which is a lie, which is legalized fraud. Another danger is that it creates a two-tiered system of dealing with suicide prevention. And as this cartoon depicts, if you are somebody who's disabled, who is costing society money, you can just take this ramp to receive assisted suicide. Whereas if you're an able-bodied person, a person who is contributing monetarily to society, you can just climb these stairs and get suicide prevention. An example of this, of how the presence of physician-assisted suicide increases the general suicide rate. We take this example, this study in Oregon. Between 1999 and 2010, basically the first decade after physician-assisted suicide was legalized in Oregon, among men and women aged 35 to 64, the national suicide rate increased during that 10 years by 28%. Whereas in Oregon, that had physician-assisted suicide, it was almost double that, up to 49%. So physician-assisted suicide creates an environment where suicide becomes more of an option to other people. This is so-called suicide contagion. So assisted suicide is not safe. It is dangerous for a number of reasons, which I have gone through. So physician-assisted suicide really is not about giving patients the right to commit suicide. It is about giving doctors the right to kill. Now, this is not like so-called pulling the plug. Patients have a right to withdraw from treatment if, after talking to their doctors and their family and the clergy, they determine that this treatment is too burdensome. Patients have the right to withdraw from care. That's not what we're talking about. We're talking about doctors actively participating in killing. And doctors, nobody should be given that much power. The group behind physician-assisted suicide is a group called Compassion and Choices. They were formerly called the Hemlock Society. And they learned that it's not really good PR to name your organization after a poison. So they changed their name to Compassion and Choices. You know, choice is always a word that people like. People like to have choices. But if you're steered towards suicide, that is not your choice. And compassion, this is false compassion. True compassion, the word compassion means to suffer with. The false compassion of assisted suicide is medical abandonment. But their two main arguments that they use is to avoid unbearable pain. But we have the best pain management in history. And it is not even the number one or two reason for people to commit suicide. It's about number 6 on the list of concerns that patients have, that patient give as reasons for assisted suicide. The other thing they'd like to use is my choice, my right. But again, patients already have the right to refuse medical treatment. And sadly, they may take their own lives. So when they say this is my choice, well, they're actually not doing it on their own. They are making the medical establishment complicit. So it's not just their life. Their suicide will affect other people. It is not just their death. Their death will affect other people. And it's not just their choice, because their choice has societal ramifications, as I've already explained. So the laws to legalize physician-assisted suicide are, again, mainly for white, well-insured, well-to-do, well-educated patients. And in fact, I was speaking to somebody just a week ago or so, somebody who was talking to one of the legislators in Massachusetts, and she was being lobbied by the Compassion and Choices folks. And she made the comment, boy, these people are really white, and they're really kind of well off. And it was kind of obvious to her that it was the white and the well-to-do who wanted this. So here was a poll that was done in 2016, I believe, in Oregon. So what are the top reasons for people wanting to have assisted suicide? They're the number one reason, less able to engage in activities making life enjoyable. Well, this isn't a reason for suicide. This should be a challenge to all of us to try to be involved with these people and make their life somehow more enjoyable. Losing autonomy, again, it should be a challenge to us to come up with ways and devices to make them more autonomous. Loss of dignity. And often this equates to losing control of bodily function. Does that make a person undignified? Are our babies and toddlers undignified because we have to change their diaper? Well, when a person gets old and is unable to control their bodily functions, does this make them undignified? It is undignified for the rest of us to allow people to feel that they are undignified. Burden on family. Well, if people are feeling like they're a burden and we agree with assisted suicide because of that, we're basically agreeing with them. Yes, you are a burden. You should end your life. Inadequate pain control or concern about it. Again, that's way down on the list. And we have the best pain medication in history. We have hospice. We have palliative care. And there's no reason in 2022 that somebody should have unbearable pain. True, we're not always able to eliminate pain, but we can make it manageable and allow people to live to the end of their life so that they can, and those last weeks and months of life are very precious. They're a time where people can forgive and seek forgiveness and reconcile. Financial implications. Well, we have a GoFundMe page for just about everything. Again, we as a society should come up with ways to help people financially afford their treatment. This should not be a reason for people to commit suicide. So in summary, physician-assisted suicide is dangerous. It's dangerous because there's a loss of trust in the doctor, loss of choices at the end of life, financial incentive for premature death, coercion by government, insurance, possibly family members. There's a lack of appropriate treatment for depression. There is no mandate to treat depression in these laws. There isn't really there's a suggestion to get a mental health consult, but often that doesn't happen. There's no teeth in that. And if somebody does assess a person for being depressed, there's no mandate to treat the depression. The only thing that's suggested is to make sure that they understand what they're doing. This is not treatment. Safeguards don't work. Safeguards are merely obstacles for the next round of legislation. They're just obstacles to be taken down. And like, for instance, the safeguard of only having 6 months to live. Well, that's inevitably expanded, but doctors are often wrong about diagnosis and prognosis. It's dangerous for doctors. Nobody should be given that much power. It's dangerous for families. They don't even need to be informed. So a patient could theoretically be prescribed the medication, go home and kill themselves, and only to have family go home and find their loved one dead. It's dangerous for society and public health. Marginalized groups, as I mentioned, are vulnerable and they'll be steered towards suicide. We already have very high suicide rates, and this will make those rates higher, as was demonstrated in Oregon and other states that have legalized assisted suicide. It's not needed because we have good palliative care and hospice, and it removes the hope for medical breakthroughs. Now, in Massachusetts, we've been fighting this for years. 1995, 97, 09, 11, 14, 16, 18, 19, 20. This is the 10th time it's before the legislature, and it's before the legislatures now, and decisions will be made within the next several weeks. We also defeated it, as I mentioned, narrowly in 2012, 51-49. So I really relate to what C. Everett Koop said. I went to medical school to learn how to save lives and alleviate suffering. I saw no tension between these points of view because I was a Hippocratic physician. There was an absolute proscription on the taking of life. If I could heal or cure, I would do it. But in doing that or failing that, I would relieve the suffering of my patient. Hippocratic medicine does not require that the act of dying ever be prolonged. If my patient has received all that I can do for him, and if healing is not possible, I can alleviate his suffering and still stay well within the bounds of do no harm. The ancient doctor of those days could cure practically nothing, and it is self-evident that he did what he could within the framework of do no harm. Here is the action slide. If you haven't been taking notes, you can take these notes. The thing that everybody needs to do, and tell 2 or 3 other people, find out who your state senator is and your representative, call them, find out, do they support or oppose assisted suicide? Better yet, ask for a meeting. You can ask for a meeting in person, or you can ask for a Zoom meeting. It's really very easy to do. If you're logged in here, you can log into a Zoom meeting with your legislator. You can ask somebody like me, and I'm willing to go with people, and I've done that before. People want to talk to their legislator. They set up a Zoom meeting. They're not quite sure how to approach it. They ask me to join them. I'll be happy to come along to a meeting, and there are others like myself who are willing to do that. But call, set up a meeting, write to them, let them know your wishes regarding this. This is the most important thing we can do. If they hear from one person, they know that that reflects 1,000 people in the community. There's the phone number. There's the web address, malegislature.gov. Contact them, call them, educate others, get others to do this. Put letters to the editor in your local paper. So we need to fight this now. It is before the legislature, and if they don't hear from us, the momentum is picking up that in favor of this legislation. And the only way to to fight this is the most effective way is to talk to our legislators.